Hello, Dr. Kostas. How are you?
I'm very well.
How's your IDS experience so far?
It's my second day today. It's my third time here in Cologne,
Nice.
and it's the event of the 2 years is the biggest event for meeting all professionals, and I'm very excited to be here again at the GC stand.
Nice. And we're very excited to have you. I saw you were today giving a lecture at the Speaker's Corner.
That's right.
Very, as usual, very beautiful cases. I wanted to ask you about when you attend an IDS, do you usually, look for something or just for a networking event, or are there technologies that you were interested in seeing this time?
Well, at the beginning, it was more about getting to do some shopping, getting to see the new scanners and the new printers.
Yeah.
But more recently, it's more about collaborations and doing demonstrations and lectures.
I see.
I've been here for 2 days. I haven't found the time yet to go and look at new stuff, but it's still exciting to teach and share all the information that I know.
I see. And talking about sharing your information, today we were giving us a presentation about injection molding. And I think you mentioned the word evolution of the technique.
Absolutely.
Yeah.
It's something that I have evolved for 5 years. The way I was doing it 5 years ago is very different to how I'm doing it now. The materials, the restorative material is the same, but the whole approach in terms of designing the wax up, making the stents, isolation in the mouth, and minimizing problems and minimizing chairside adjustments is crucial. So I'm pretty sure that in 2 years from now, I'm going to be making more changes, maybe with printed stents and fully guided stents. So it's an evolution, absolutely. But I have pioneered this technique in the UK over the last 5 years, and I have trained about 850 dentists across Europe and beyond.
Where do you see the challenges are for dentists who try to apply this technique? Obviously, you trained hundreds of them, so
Yes.
is there like common
There are
challenges?
two challenges. I have a group, a chat group with 650 people, and the most common barrier that they present is firstly finding the right lab, which is going to design the wax up specifically for this technique and make the right stents. And the second barrier is shade selection. So this technique is primarily designed for monoshade, for monochromatic. I do layering, I teach layering, but the main indication is monochromatic. So which composite to use for which situation. And for the lab side, yes, the dental technician will not just make a standard wax up. It has to apply specifically to this technique. The embrasures have to be different, the cervical adaptation of the wax has to be different, checking the thickness of the wax for posteriors is important. So it's not just an ordinary wax up. Otherwise, the cleanup is going to be very messy and the dentist will be frustrated.
I see. So it starts with the lab, basically.
The magic of the technique
Yeah.
is all about the design and the wax up. The execution of the technique is not that hard. There are a few mistakes that can happen. You can do things wrong, but if you have an excellent wax up, it makes life very, very easy.
I understand. And maybe a common challenge also, like many dentists have with this technique, is how to have the rubber dam and in place and
Correct. So at the beginning of my injectable journey, 2019, 2020, all my cases were without full rubber dam isolation. I could not make it happen. But in the last 2 years, I have found ways to have a full inverted rubber dam, you need a thick dam sheet, which is going to fully be inverted into the sulcus. And then the stent has to accommodate for the clamp, it has to accommodate for the rubber dam, so no soft tissue referencing. You have to rely on the hard tissues to get the support. And if you're going to use rubber dam for injection molding, you have to put your A game to it. The rubber dam skills have to be excellent, not just average. So it requires some training and hands-on practice with rubber dam.
I see. And then, using an alternate tooth method,
Correct.
for example, do dentists also have a problem from your experience, people who train, kind of isolating the teeth? Because, for some reason, many people struggle with the Teflon, with the isolation of the Teflon and
Yes.
the leakage of, like, for example, for some fluids, from the sulcus. How do you direct these people?
The technique is designed to work on the alternate tooth technique.
Yeah.
We are not going to inject the premolars and the molars all together. Otherwise, they're going to get stuck to each other.
Yeah.
So the best way to do that is with Teflon tape. Placing the Teflons on the posterior teeth is harder than the anterior teeth.
Yeah.
So what I use some thin metal strips to loosen the contacts proximally, prepare the contacts for the Teflon tape,
Yeah.
because after injecting, the contacts will be very tight anyway. Now, one other thing that can help with referencing is to use the two-stent technique. So if I am working on 4 posterior units and I'm doing 2 premolars and 2 molars for a tooth wear case, and tooth wear is the main indication for injection molding, I will fabricate a model from the full wax-up of the 4 teeth, and I will also fabricate a second model where the wax from the alternate teeth has been removed. So 1 premolar and 1 molar have nothing on them, and the other 2 have the full wax. So I will make 2 stents, 2 clear silicone stents using Exa-Clear from GC, and I will start with the alternate first, where 1 tooth is short, 1 is long, short, long, and that will allow me to have good landing on the teeth, good referencing, without moving about. And after I complete the first 2 teeth, I will then use the other stent from the full wax up to complete the treatment. So rubber dam is not going to be a barrier, is not going to be a problem. You have to utilize whatever support you can get, and the 2-stent technique helps.
I see. Thank you very much for sharing all this information. Probably hearing this from one of the biggest experts in the field will help so many dentists out there. So, we were talking until now in the preparatory parts, for example, and the placement of the rubber dam, material selection, for example, or shade selection. Like you mentioned, some dentists struggle with it.
Yes, it's a common question.
Yeah.
And it's not just applying to Genial Universal Injectable from GC, it applies to all flowables. If you are treating a tooth wear case or a case for composite veneers, it's quite possible that if you inject all the teeth with one shade, you may get different outcomes. You may get different islands of color. So the shades of Genial Universal Injectable, they cover both the universal Vita world with A1, A2, A3, and so on and so forth, but also the classic Genial family of dentin and enamel, the world of layering. So I do quite a bit of layering. Layering is something that is needed a lot in the freehand world, in the freehand world, we rarely go with monoshades, just one. And layering is helpful also in the injectables. So my advice to dentists who start using this technique is to do a mock-up, a test drive, before you actually inject with, let's say, an A1 Gillian injectable case. You're not going to use etching gel, you are not going to use adhesive, you are just testing the color. And by doing a few test drives and a few mock-ups, but with the actual restorative composite, not with a temporary resin, you actually get to see precisely what you were going to get with A1 or A2. So the first few cases that dentists attempt, I suggest they do a genial injectable mock-up. It may be a little bit of an expensive mock-up, but it's very educational and you learn the shades.
I see. So not for all the cases, but when you're just trying out?
At the beginning of, like any composite, after a few cases, you learn the material.
Yeah.
It doesn't matter if it's a GC material or not. So it takes about 5 cases, in my experience, to learn the shades of Genial Universal Injectable. They are a bit glassy, they are a bit translucent. I use this as an advantage, and I know them very well. So doing a bit of practice without etching and placing the adhesive is the best way to learn the shades.
I understand. So regarding material selection, thank you for sharing all this information with us. Something else that we might have skipped it within the conversation is like case selection for injection molding.
Yes.
What
It's
would you
a hot topic.
right? So to use this technique or not to use it with tooth wear, for example, in areas with high loading, for example. What is your recommendation for a dentist that might be interested in getting into this technique?
Yes.
But to be on the safe side, for example.
I understand.
Yeah.
This technique is not the right technique for many, many things. So if you're dealing with caries, it's probably not the right technique. It's not really a technique for single tooth dentistry. It's a technique for more global dentistry. You're doing 4 teeth or 6 teeth or full mouth. It offers an advantage of anatomy, which you do not have to determine with manual sculpting. And it's more useful when you're doing bigger cases. Now, the 2 main indications for this technique is tooth wear, the wound dentition, where usually you have to change the occlusion. And the other indication is facial composite veneers, where you know that you're going to get symmetry on the morphology because it's predetermined and pre-approved. Now, there are limitations. If you are doing a tooth wear case, you need the prosthodontic skills on how to control the occlusion, on how much to add. And what I have learned now that I didn't know 5 years ago is that I am very generous now with occlusal addition on the posterior teeth. I will add minimum 1 millimeter to 1.5 of composite, not just thin amounts, because it is composite and it will be getting worn away very easily or chipping. So I am generous with my posterior additions on the name of longevity. I have 5-year follow-ups where, yes, there have been some chippings, yes, there have been some repairs and disking, but composite is like that. It's high maintenance. And many of my long-term follow-ups, they still survive after 5 years. we do not need to do them again from the beginning. But what we don't have yet is the clinical evidence, the clinical performance study to tell us exactly how many complications to expect and how many years should we expect. But I'm doing that research.
Well, I was about to ask you, are you doing that?
I am.
Yeah.
It will take another year to publish it because I have 40 cases and it just takes a bit of time to publish.
I see. I'm looking forward to this, Okay, in the end, if we can go with one takeaway from this podcast or from lectures that you give away that you would like our listeners or viewers to keep in mind when trying to use this technique, what would it be?
Two very important messages is first of all not to see this technique as a substitute to freehand dentistry. This is a fully guided technique. This is a cheating technique, but it's not a replacement for your flat plastics, and it's not a substitute for learning how to shape anatomy. So in university, I ask all my students to learn how to shape a tooth first, and once they are happy with normal anatomical contours, then they can use this technique. It's not just an easy way to get great morphology. And the second thing is in whatever country you may be, watching a video or watching a YouTube or one of my podcasts or whatever is not enough. Unfortunately, it requires some hands-on practice.
Yeah.
So find an educator near you, spend a whole day practicing the technique. There are 5 to 10 mistakes that can be done. Make these mistakes, learn from them, so that when you go into a real patient case, you are feeling confident. It's not just from a webinar or an online video. It requires hands-on practice.
Hey, thank you very much, Doctor.
You're welcome.
Appreciate it.